Good afternoon, everyone. I'm Diane Perez, and on behalf of the Florida Alcohol and Drug Abuse Association and JBS International, Incorporated, welcome to today's webinar entitled Supporting Mothers and Babies Affected by Opioid Use Disorder. This webinar is being made available through a collaboration of the Florida Department of Children and Families Office of Substance Abuse and Mental Health, JBS International, Incorporated, and the Florida Alcohol and Drug Abuse Association. Please note that as an attendee, you are in listen-only mode and will only be able to view your name. If you have questions, please send them to the presenter and me, the host, by using the Q&A panel. The button to open the panel is usually located on the upper right side of your monitor. Please use the Q&A panel to send any questions you may have as you think of them. The presenter will address questions as time permits. Our audio is broadcast through the internet to your computer. If you experience poor computer audio, there are a few options to try on screen right now, and these options will be posted in the chat panel too. If you continue to experience poor audio through your computer, try rejoining the webinar and call in using the telephone I will call in option. You must be connected to the audio of this presentation and view it on screen as well to receive a certificate of attendance. The recording and materials used in today's presentation will be available on the FADA website within 10 business days. To access the recording, go to www.fada.org. Also, a PDF version of this PowerPoint presentation will be emailed to participants. FADA produces many webinars and workshops through the support of the Florida Department of Children and Families. To help participants track credits earned through attendance, we host an online community that provides a personalized digital journal where participants can maintain statements of credit for webinars and workshops taken through the Florida Alcohol and Drug Abuse Association. At the end of today's webinar, the web browser will direct everyone to an evaluation form on the FADA website. You will first need to register or sign in to your account to complete the evaluation. Information you provide FADA as part of the registering remains confidential. Statements of credit will be posted within 10 business days after the evaluation closes in individual professional development journals for persons completing the evaluation and attending the full webinar. Completing the evaluation is necessary to receive CE credits or to access your statement of credit. Do note that the evaluation will close at midnight on Saturday, March 2nd. 1 to 2 continuing education credits are available for participating in today's webinar for persons licensed through the Board of Nursing, the Board of Clinical Social Work, Marriage and Family Therapy, and Mental Health Counseling, and for persons credentialed through the Florida Certification Board. If you are licensed healthcare practitioner, be sure to include your Florida license numbers for reporting to CE broker when you register with our site for the first time. If you are certified with the Florida Certification Board or licensed outside the state of Florida, you don't need to provide your certification number when you register with our site. Note, please, that WebEx monitors arrival and departure of attendees and provides a report upon completion of the event. We are not permitted to provide contact hours or a certificate of attendance if you do not attend the entire webinar. We are not permitted to provide partial credit. I would like to introduce Dr. Melinda Campopiano von Klimo. She is Senior Medical Advisor and earned her MD from the University of Pittsburgh. She is a family physician. Melinda is board certified in both family medicine and addiction medicine. Over her 20-year career, she has practiced the full spectrum of family medicine, including obstetrics and pediatrics. She also treated addiction in her primary care practice. Later, Melinda was medical director for the Western Psychiatric Institute and Clinic Narcotic Addiction Treatment Program. Her clinic provided specific services for pregnant women, including those incarcerated in the county jail. Until she joined JBS as Senior Medical Advisory in 2018, Dr. Campopiano worked at the Substance Abuse and Mental Health Services Administration in the Center for Substance Abuse Treatment. She led the development and publication of key SAMHSA resources, including the Opioid Overdose Prevention Toolkit, Treatment Improvement Protocol Number 63, Medication-Assisted Treatment for Opioid Use Disorder, Clinical Guidance for the Treatment of Pregnant and Parenting Women with Opioid Use Disorder and their infants, and others. She liaised with federal, state, and local criminal justice and law enforcement organizations and collaborated with the National Center for Substance Abuse, Child Welfare, and the Federal Administration for Children and Families. And now I'd like to welcome our presenter, Melinda. I will turn the presentation over to you.
Thank you, Diane. And I'd like to just acknowledge FADA for creating this opportunity for us to have this webinar. I'm just testing my little tools here to make sure things move along. Yeah, that seems to work. So that information's been covered. There we go. So this is what I hope to cover most intensively for you today. By the end of this training, you should be able to understand the impact of the opioid epidemic on women and infants, recognize and support the delivery of optimal care for pregnant parenting women with opioid use disorder, discuss the role of pharmacotherapy and treatment during pregnancy and the postpartum period in promoting the health of the infant, and understand neonatal abstinence syndrome, or NAS, and the strategies for minimizing and managing it. So without further delay, we're going to go into the impact of the opioid epidemic on women and children and look at the epidemiology. So first, a little bit of terminology. Many of you will be familiar with the terms opiates and opioids, and it's not that important to use the specific term at specific times, but they do have different meanings. So opiates are chemical substances that occur in opium or that are derived from chemicals that you find in the opium. So codeine and morphine are both in opium. Okay, so if you ingested opium, you would test positive for codeine and morphine. Heroin is not present in opium. It has to be chemically modified from morphine. Okay, now opioids always used to just mean those things that work like an opiate but are completely chemically synthesized in the lab that were never in an opium poppy. Okay, things have gotten a little more complicated since the advent of this, what gets called synthetic fentanyl analogs. You'll see the term usually in the popular press or media, not so much in medical journals or anything, synthetic opioids. And this generally so far is used to describe those non-pharmaceutical opioids. They may be the exact same molecule as the pharmaceutical drug, but they're illicit, so they're non-pharmaceutical. So that's the fentanyl, carfentanil, fentanyl analogs, all those different things that you hear about that are turning up in heroin, that are turning up in cocaine and being sold as fake pills. So that's just kind of the advent of fentanyl in the illicit drug market kind of complicated our terminology a little for us, but that's all I'm going to say about that. I am going to mention that as I go through this and I talk about the medications that are used to treat opioid use disorder in pregnancy, I am conditioned to use the generic names. So I talk about methadone, buprenorphine, and naltrexone. And when I say buprenorphine, I mean what a lot of people call Subutex. You may know it as Suboxone, but it's actually not exactly the same thing as Suboxone. And then naltrexone is the injectable drug that's Vivitrol. Okay, so I'll be using the generic names as we go along, and I'll point it out as I go. So now the national picture with regard to the opioid epidemic in women of reproductive age hasn't changed much between the most recent statistics, which are those from 2017, released late last year, and the year prior. So it's kind of good news, bad news. It didn't get any better, but it didn't get worse in a way that's statistically significant. Now, if you're on the front lines, what's statistically significant is not always that important, because it's still very significant to tens of thousands of people who are experiencing substance-exposed pregnancies and delivering newborns exposed to substances. So the pregnant women are, in terms of the statistics, not getting that much worse as a population, but they're not getting better either, so they're considered a population of concern. Now, Florida fits into the national picture, and it's difficult to get the data just on women of reproductive age. So this is kind of all people over 12. With regard to pain relievers, you're in the lower end of the spectrum. But if you look at the little scale here that tells you what the colors correspond to, you'll see that there's only a couple tenths of a % difference between the different layers. So the percent of the population with past year pain reliever use in Florida is only a few tenths of a % or 1% lower than in the worst states. So it's better than being, a 1% higher, but it's not a big spread, you might say. Now, similarly, for heroin, Florida stays on the lower end of the percent of population that reports past year heroin use. And because relatively compared to the population of 300 million, very relatively few people use heroin, you'll see that the differences here are maximum one-tenth of 1%. It's more in the hundredths of a percent. But it's enough that they can detect a difference between state populations. And Florida's generally on the lower end at this stage of things. And you may notice if we look at these two where the red states are on these two, those are also the states where you tend to hear in the news that they're having the higher rates of overdose. So it's a sort of a multifactorial problem. Now, back to our population of concern, pregnant women, the other thing that's of concern is not only that we're not making improvements, is that we tend to see not only the data with regard to opioid use kind of going in the wrong direction, but the general trend for marijuana and cocaine use in pregnancy is going in the wrong direction. And I mention this because we're all about opioids right now, and the funding streams are all opioids, opioids, opioids. But this really is one piece of a bigger problem. And right now we're hyper-focused on the opioids, but as you're learning and taking on new things in your professional areas, it's helpful to just kind of keep an eye on the broader picture. So now this is national data because they don't release a lot of the state level data because the population numbers start getting so small that in some states you can't guarantee people's privacy. So when you look at past month use of heroin or prescription opioids in pregnant women, you find nationally that the estimated number of pregnant women with past month use of either of these opioids is 32,000. So when I see a number like that, I think we ought to be able to do something about 32,000 people, right? We ought to be able to handle 32,000 people as a country. Now, non-pregnant women of reproductive age is closer to 1 million women who report past month use of heroin or prescription opioids. Now, just taking my longer perspective in my recent past federal service, I can remember when it was 20,000 pregnant women. So over the last few years, it generally has gone in an unfavorable direction. So there are some unique aspects to opioid use disorder for women in general that don't get discussed a lot in the bigger context of the epidemic. First, women experience a faster onset and progression of opioid use disorder than men do. So they become addicted faster, and they move from use, misuse into use disorder, which is the more advanced severe disease, faster than men. And they also experience greater social and occupational impairment than men do. So it impacts the way women handle their social and occupational burdens, maybe magnifying some challenges that are already there between how women are handled in the occupational fields as opposed to men. And then women are also less likely to engage in treatment than men. And it's speculative, but it would make sense that it's because of the shame that's associated with it, regardless of whether you're pregnant or not just the access issue. So looking at this now again in pregnancy, what do we know about it? What figures can we actually cite? So opioid use disorder has increased among pregnant women in all states. It's estimated that 6.5 women per 1,000 have opioid use disorder, so diagnosed of addiction at delivery. That's not just substance exposed. Pregnant women who took opioids for non-medical use were more likely than non-pregnant women to obtain their opioids from doctors. So what does that mean? It means that pregnant women might be getting a little bit of a safer supply of prescription opioids during their pregnancy, but otherwise we can't really explain what that difference is here. Maybe pregnant women are given the benefit of the doubt, or doctors are more willing to provide them opiates to keep them safe. Hard to know. There has been a sustained increase in both maternal opioid use disorder and neonatal abstinence syndrome diagnoses in the babies among rural residents. And you'll see as we go through, there's kind of a theme about rural residents. And I'll just mention that you might kind of go, duh, when you say, oh, well, if there's an increase in maternal opioid use disorder, of course there's going to be an increase in neonatal abstinence syndrome. And you're right, but it's not directly one-to-one, because an infant could be exposed to opioids during pregnancy from a mom's treatment or from her substance use and not experience NAS. It's not 100% guaranteed, but we'll go into that some more. Now, prevalence, and here we were talking about incidence of opioid use disorder increasing. This is prevalence, so how common is it? Again, it's significantly increased in the last 20 years of the epidemic. It affects, like I said, a relatively small population. If you say 36,000 women is small. So it hasn't gotten as much attention until recently, but it's been there and growing in parallel with the epidemic all along. Now, in the postpartum period, we tend to get really focused on the pregnancy period because we're worried about what the infant's being exposed to. But postpartum period has some particular challenges to it that might ultimately be as hazardous for the infant as things that happen during pregnancy. The intense stigma of having a substance-exposed infant is a big complicating factor in how women are treated and how they navigate what they have to as new parents. At the same time, they're experiencing the hormonal changes of post-pregnancy, and they're at high risk of depression, postpartum depression. This is a period of time when they're more likely to leave treatment. Oftentimes, if their pregnancy was covered by Medicaid, they no longer have that for their own health or their treatment. And there's a high risk of relapse to other substances, even if they're in treatment, they continue in treatment for their opioid use disorder. So, you know, if just to take a moment to kind of think about it, if you have children, you know, if you have a sick child, even if it's just a complete, you know, bad luck thing, there's a tendency to want to, for some people to think, well, what did this mom do, you know? And there's a tendency for the moms to blame themselves if their baby has a medical condition at birth. So imagine that magnified by all the social stigma and the self-blame that mental illness and substance use disorder create for the woman. And it's just kind of a nightmare, perfect storm of stress and physiologic changes and mental health challenges. Now, I'm going to mention tobacco use because tobacco use is known to cause pregnancy complications. It restricts infant growth, may be associated with preterm delivery, to be associated with developmental issues in early childhood and in the school years. So just a quick look, pregnant women do still smoke. They smoke less than non-pregnant women, which tends to be what you see with any kind of substance use. Women who use cocaine use less cocaine when they're pregnant. So this parallel that you see here around daily cigarette use and tobacco use of the past month, where pregnant women, 9% for cigarette use and almost 15% for tobacco use, compared to 10 and 20% of non-pregnant women, is pretty typical. And tobacco use, let me go back for a second. Tobacco use is actually pretty strongly associated with neonatal abstinence syndrome. So I'll talk about it more later, but stopping smoking when you get into treatment while you're pregnant, it can be a really important neonatal abstinence syndrome prevention strategy. Because the truth is, clinically, when the baby is manifesting the symptoms of withdrawal, some of what we're looking at may be nicotine withdrawal, but we have no way to sort out what portion is opioid and what portion is nicotine. So it's a challenge in clinically effectively addressing these problems. Now, alcohol use. Alcohol, again, is a known teratogen. It's known to cause birth defects. It is known to cause lifelong developmental problems. So we're very focused right now on these infants who experience withdrawal at birth, but we have two substances that are known to cause very serious problems that we can't forget to address because it affects much larger numbers of women. So I won't go into these statistics because they're not that relevant to the immediate discussion, but it's just a bigger portion of the population, really. So the other thing to know about is tranquilizers and sedatives. These are usually the benzodiazepines, Xanax, Klonopin, things like that. These are very strongly associated with pregnancy complications and neonatal abstinence syndrome. And they are becoming a little bit more widely misused because they are also overprescribed, but we don't hear quite as much about them. You can see that it's roughly half, where when we were looking at opioid use in pregnant and non-pregnant women, it was like 1 million for non-pregnant women with past month opioid use, and here it's over 500,000. And for pregnant women, it was 36,000. This is 18,000. So, but it definitely magnifies impact for the substance exposed pregnancy and the infant. Now, overdose obviously is a plague on all of our communities right now, and so let's take a minute to look at how this affects pregnancy in particular. In one study, 14% of pregnant women reported a non-fatal overdose in the past year. Doesn't necessarily mean that the non-fatal overdose happened during the pregnancy, but it's kind of a marker of how common that experience is for people with opioid use disorder. In this study, younger age was the only risk factor that was consistently associated with a higher likelihood of reporting this experience of a non-fatal overdose. Most of the study participants said they had received opioid overdose education and had naloxone, which is a good thing. More importantly, because I think this is something that gets overlooked again because we're focused on the pregnancy, is another recent study found that the risk of overdose was 4 times higher in the postpartum period than in the 3rd trimester, and that the risk of overdose was highest in the period 7 to 12 months postpartum. So again, we are very focused on the pregnancy, the newborn period, and what we may be needing to look at if we want to, reduce the number of children being raised by their grandparents, for example, is what's happening in the late postpartum period that could be changed to reduce the number of women that are dying in that period. So we'll talk about that when we get into the treatment stuff. But I think this is very important. If some of you are working with Child Protective Services, and so you may be following a child from birth and see the loss of the mother in the late postpartum period. So maybe close to your professional experience. So just to summarize this section, as I babbled about some numbers, which can be kind of tedious to listen to on a webinar. Take-home message is that while the epidemiologic statistics are not necessarily looking that much worse, women and pregnant women in particular remain a population of concern nationwide. Women do appear to become addicted more quickly and with less drug use, and they suffer more harm due to drug use, particularly social and occupational harm, where they may already be facing challenges. Tobacco and alcohol are both long-standing known to harm pregnancy and the infant, and need to be addressed as part of addressing the opioid epidemic. And the risk of overdose is highest during the postpartum period, especially the late postpartum period. Now, I'm going to take a quick drink of water, and I'm going to mute you. It'll just be like 10 seconds here. We'll go on to the next slide. Okay, thank you for letting me not cough in your ear and have a drink of water. So now we're going to turn our attention to what constitutes optimal care for pregnant and parenting women with opioid use disorder. Some of you are more in your professional capacity, more involved in caring for the infant, some for the mother, but even after the baby's born, the two can't really be separated in terms of if one's not getting optimal care, neither is the other. So Diane kindly mentioned the document that SAMHSA, that I helped with SAMHSA's production of, called Clinical Guidance for Treating Pregnant Parenting Women with Opioid Use Disorder and Their Infants, which is a title that just really rolls off the tongue, but we wanted precision. So this is a document that you can download or order a print copy of from SAMHSA, and it's meant for healthcare professionals of any discipline. It's not targeting just physicians or just nurses or something like that. I think it could be useful for people who are not necessarily health professionals but are working with families and want a little bit more understanding of what's supposed to be happening for the mom and the infant. The way it's set up is it's organized around the patient. So if you have a person that you're responsible for in some way who's in late pregnancy, in treatment, planning for labor and delivery, you can go to the place in this guide that's like, in treatment, late pregnancy, planning for labor and delivery, and see in like a 2-page layout what is supposed to be happening here. What are the important clinical actions? And then if you're curious, you can turn the page and it goes through it in more depth, and then you can turn another page and you'll find like additional resources. This isn't the kind of resource that you're going to read through because it's kind of set up deliberately to be a little repetitive. Now, there are a set of fact sheets that you might find useful in your setting. Some of them are targeting care for the mom, some for care for the infant. But these are also freely available from SAMHSA, and you can reproduce and use as you see fit. And I think they even left a little space where you could potentially put your logo or contact information or something on there on the bottom somewhere. So anyhow, I think this could be useful to some of you who are responsible for working out what a plan of safe care is going to look like, especially since it has to include what should be happening for the mom. So I think you may find useful tidbits in the information that I'm going to cover and in the resources I just discussed. So I think this won't be any surprise to anybody that it's more often that a woman has an opioid use disorder and becomes pregnant than it is for a woman who's pregnant to develop an opioid use disorder. That almost never happens. Women, their route to the initiation and development of opioid use disorder is complex. There's a few things that I think you will have noticed already, and these are childhood history of physical, emotional, sexual abuse or neglect, psychiatric comorbidities, and a lot of times intergenerational substance use or problems with trauma or abuse. Obviously, economic challenges don't help anybody much with anything, neither does chronic stress. Poor nutrition and food insecurity. I think if the research continues, I think we're going to find a strong connection there. And what's not mentioned, and actually I'll mention it again later because there was just a study, but I have a feeling that stable housing would probably be strongly associated. It's just very difficult to measure. So there's a lot going on in the woman with substance use disorder even before she becomes pregnant. So I don't want to belabor what I imagine you're already fairly sensitive to, which is the fear that drives some of the poor choices that a pregnant woman might make, for example, to avoid engaging in treatment or to delay seeking obstetric care. When we were developing the product for SAMHSA, we had the opportunity to have some focus groups with some patients, some women at University of North Carolina Horizon program. And you see a quote there from one of the ladies who attended their programs. But fear of loss of custody of children, lack of funds to pay for services if they're not covered by Medicaid, or after the baby's born, they don't have Medicaid anymore. The burdens and time costs related to transportation and childcare. All of that makes it just that much harder for women to engage in treatment. The transportation, I can't emphasize enough what a huge problem that is in the more sparsely populated areas. We're not even talking about the frontier states, but just the rural areas where everything's a long drive away. It's a huge barrier. Now, what is recommended is that all pregnant women are screened for substance use disorder, not just opioids, but substance use disorder. The screen should be an interview or a questionnaire type thing and a urine toxicology screening or urine drug screen. Both are needed. You'll tend to see one or the other, but really both are more appropriate. So this can be something that when you're looking at a family or a patient, depending on what your role is, and you're trying to decide, are they getting good quality care? Well, did these things happen? And that can just kind of, just be some of the knowledge that you glean about what this person's quality of care might be. So you also want to talk about treatment history, but we're going to get into that. So screening to be effective needs to, like I said, cover alcohol and tobacco use because these and marijuana are the most common substances misused. The screening should ideally look for high-risk behaviors, such as injection drug use, the increased risk of sexually transmitted infections should be considered, and then screening for depression and anxiety, both of which are strongly associated with poorer outcomes and something that pregnant women, even without opioid use disorder, are at high risk for. Those should all be screened for. Now, probably the most widely used, but certainly not the only screening instrument, is the 4 Ps that asks about drug and alcohol use, your parents, your partner, your past, and this pregnancy. And then there's one more that people are using more and more. That's I call the 4 Ps plus 2 Ps, because it's your parents, and instead of partners, it's peers. Parents, peers, partners, pregnancy, and then it's got this past month and smoking questions. So it's just a slightly expanded set of questions, and it gets some different information. I think what tends to happen is people use this one, and then when they get positives, they just ask, well, was that during the last month of this pregnancy? Oh, your partner doesn't use, what about your closest friends, the people who are going to be supporting you when you have this baby? So it kind of flows naturally into the patient interview. Now, informed consent, those of you who are healthcare professionals will be well-versed in obtaining informed consent. What's important to remember is that testing a pregnant woman for controlled substances or illicit substances requires informed consent. Now, it doesn't have to be a signed paper or electronic form, although that's preferred. It can just be oral and then documented. It needs to be written down that I spoke with this person and I disclosed, I went over this and this and this, and she agrees to X. So it should be at the very least orally covered and written down. So there are risks and limitations for each type of test. And I think the most important thing is most tests are screening tests. And in the context of pregnancy or other really high risk, high vulnerability situations, any positive screening test needs to be confirmed. Because screening tests are meant to not miss anything, okay? So they can sometimes be tricked by similar molecules because you don't want any that come back negative when there was actually a drug present, okay? So if you screen positive, there's a good chance that the test is wrong. There's a better chance that the test is right, but there's a good chance that it's wrong. So in a situation where somebody's, pregnant, or this is going to be a parole violation, or their child's going to be taken away from them, or they're going to lose their housing, that needs to be confirmed because a screening test is too is just not strong enough to make a high consequence decision on the basis of it. So this would be something to watch for. If you're looking at somebody's urine drug screen came back positive, the next question is, was there a confirmatory test? If you're not seeing that, then you may be dealing with a person who's not getting optimal care. So most of the time, if you're not directly in a drug addiction treatment program, you're not going to be involved in deciding what gets screened for. Most of the time, it's a panel, so there may be one or two other drugs that get added because they happen to be common in the community, but it's relatively fixed set of things. Some programs test for markers of alcohol, some don't. Some use a breathalyzer. So alcohol can be a little more tricky to test for. And again, it requires patient consent. And it is not a substitute. It's not an easy way to avoid having a challenging interactive conversation about one's use of substances. Because it just doesn't tell you everything. It's like a snapshot. So what should the assessment look like for the pregnant woman with opioid use disorder? It's going to look pretty much like any kind of substance use disorder intake assessment. You need kind of the quantitative information: how long, how much, what kinds, by what means. You want to know about past treatment. Have you had this type of treatment, that type? How did it go for you? Did it work? Why didn't it work? And then you want to get an idea of how much the person's function is being impacted by their substance use. Some people stay pretty high functioning and they keep a fairly intact life in terms of what we sometimes call recovery capital, meaning they stay employed, they have their own housing, things like that. Other people lose all of that, and they lose all of their social connections and their family support and everything else. So the other thing, like I said, you're going to see two things kind of trend through here: rural and comorbid psychiatric illness. You want to see that this is if it's been identified, what's being done about it. So, if you're responsible for the infant safe plan, you want to know, and you see the mom has depression, you need to see that there's a plan for what's being done about that depression, because her having a comorbid depression is associated with less than ideal outcomes. So just as a way of applying this to situations you might be dealing with, that would be how I'd suggest you look at it. Now, treatment plans out of substance use disorder programs, if you've read a lot of them, they often sound very alike. And that has to do a lot with the professional jargon that gets adopted in treatment settings. But you can and should ask some questions, because there should be enough different about a treatment plan for a pregnant woman compared to a non-pregnant woman, or a patient who's not doing as well compared to a patient who is doing well, for you to be able to see that these two people are receiving appropriately different intensities of services. There should be some indication that the services are being individualized based on the patient's input, their needs, their demographics, their preferences. In the context of opioid use disorder, there should also be medication in pregnancy. And if there isn't, we're going to talk about the use of medication and how they're selected and so on. But that should be there as well. Over the course of my career, I got heard a lot of frustration from people, mostly in criminal justice settings, drug courts and stuff, that treatment plans from addiction treatment programs were all just kind of this boilerplate, almost the same for every single patient. So it's something within the field of addiction treatment we probably need to work on a little bit. But you shouldn't be afraid to ask some questions, ask for more information, so that you can fulfill your professional responsibilities with regard to, the mother or the infant, or both together, whomever you're responsible for. Again, collaboration coordination should feature in the care plans as well. If a program's not accommodating the pediatric appointments or the obstetric appointments in terms of scheduling flexibility and things like that, that might suggest that this patient's not getting optimal care. There may be a reason for it, which is why you should ask, but it should draw your attention and make you scratch your head. The other piece is patient education. Pregnant women with opioid use disorder, one of the things that I spent the most time on was their smoking cessation. I didn't tend to see as much comorbid alcohol use in pregnancy, but most of them smoked. And I tried to be careful not to make people feel additionally shamed because they're smoking while they're pregnant. The way I would go about it is I would say, you know, cigarette smoking is associated with more and stronger withdrawal for the baby when the baby's born. It's a more intense neonatal abstinence. It's one of the things that's most predictive of neonatal abstinence syndrome is smoking. And so as a mom, you have some control over that. You have the capacity to make a decision to change that behavior. And I'm telling you that not so that you have something else to feel bad about, but I'm telling you that because I don't want you to be sitting there holding your baby while it's going through withdrawal and be thinking, why didn't somebody tell me that there was something I could have done? So that's kind of how I frame it. And again, if they can't stop completely, cutting down. And it's a little controversial whether nicotine replacement is appropriate. I would just say if you see that happening, it's probably not wrong. But if you don't see nicotine replacement, it's probably not wrong. The other thing is breastfeeding. A lot of people, it's becoming more well known, but a lot of people just think, you know, oh gosh, a woman with addiction breastfeeding, that just doesn't click for me. When really breastfeeding, the benefits of breastfeeding are just enormous. And then the potential for the skin-to-skin contact and the breastfeeding experience to help reduce neonatal abstinence syndrome is big. So it's be like turning away a freebie, you know, to not have them breastfeed. It could mean the difference between an infant having neonatal abstinence syndrome and not requiring medication because they breastfed, or requiring medication because they didn't breastfeed. The other thing to just be aware of is that, you know, the women with opioid use disorder often are a little reluctant to go to the parenting classes with the quote unquote, you know, normal people. They just feel like they stick out like a sore thumb. A lot of times they don't even want to go on the, you know, tour of labor and delivery with the other moms because they just feel uncomfortable. So, you know, if your work provides you with the opportunity to provide classes or tours specifically for this population, it might be something very worthwhile and gratifying that you might do. So all the same information needs to be communicated to whomever is going to be the key support people for this woman when she has her baby, whether it's her sister, her best friend, or a partner, or her mother. Because if you've ever had a baby, every aunt, cousin, former neighbor comes in and tells you what they think you ought to be doing. And women with substance use disorder are really vulnerable to getting really bad advice. So as professionals, we need to make sure that they and those around them have the accurate information. It doesn't guarantee they will make the best decision, but if they don't have accurate information, they don't even have the option of making the best decision. So this information, like, yes, breastfeeding, rooming in after delivery, skin to skin, low stimulation. You know, sometimes after you've given birth and you're there with your baby, it's like a party in there, balloons and noisy toys and jingling things and stuff. And that's just, has no place in the environment of a child at risk for neonatal abstinence syndrome. So there, I'll get off my little soapbox. Now, you probably have heard stories about, infant born, boom, in withdrawal. That doesn't happen very often. It tends to happen if mom was already in pretty intense withdrawal when she went into labor and it wasn't addressed. More typical is for neonatal abstinence syndrome to start to appear within a day or two. They recommend that infants be observed for something around 5 days before they're sent to a less supervised environment or home. In some cases, neonatal abstinence syndrome can begin up to 2 to 4 weeks after birth. And for it to start so late, it may be associated with what kind of opioid the mom was taking, or whether maybe the child was premature or something like that, because sometimes they're just not physiologically developed enough to manifest the withdrawal symptoms right away. Key message here is reducing the dose of pharmacotherapy prior to delivery will not reduce the risk of having neonatal abstinence syndrome or its severity. This is a question that a lot of women, it's sort of intuitive. If I take less medicine, the baby has less chance, right? It doesn't actually work that way. So if you can redirect women to their treatment provider about these dosing considerations, but reinforce the idea that the amount of medication does not predict whether the baby will have neonatal abstinence syndrome or how severe it will be. Smoking cessation and the minimization of other substances, in particular the benzodiazepines, are the most important strategies for reducing the likelihood of neonatal abstinence syndrome and minimizing severity. Those are the things we know are effective. Now, in substance use disorder, relapse will happen. So unfortunately, it will happen during pregnancy as well. You need to anticipate it. Ideally, the woman should have a plan. Like, if I relapse, this is what I'm going to do. I'm going to call, my sponsor, my counselor, my friend, and I'm going to come into the doctor and get assessed to make sure I'm okay. It can be that simple. Very often in pregnancy, a woman who's maintained on methadone or buprenorphine, she gets into the latter half of pregnancy. Her dose may need to be increased, or it may need to be split into a twice-a-day dose instead of a once-a-day dose. So staying ahead of that can help prevent at least relapse related to the dose becoming ineffective or inadequate. And sometimes it's just the stress and anticipation, and a relapse may be a sign that a woman needs to be in a more intensive level of care with her medication, but with more services, more support, such as might be available in residential treatment. So that's important. I already talked about the split or the increased dosing. A relapse to another substance can interfere with the effectiveness of their dose of methadone or buprenorphine for their opioid use disorder. It changes the metabolism and just destabilizes them socially and emotionally as well. Now, if you relapse to a sedating drug like a benzodiazepine or alcohol, it can increase the risk of respiratory depression, even for the woman who's in treatment. And then if you're, even if you're taking your medication and you're abstinent from opioids, but you're engaged in the kind of behavior that goes along with an active addiction to another substance, it's going to interfere with you benefiting from services, keeping your prenatal appointments, and so on. So it all has to be addressed. Now, this is, again, kind of information that not trying to teach you how to do it, but to know that a woman with an opioid use disorder, whether she's on treatment or not, is going to need pain control during labor and delivery. More often than not, non-steroidal anti-inflammatories like ibuprofen are adequate. But women can also be prescribed short-acting opioids like Percocet. If you don't see something prescribed for pain, that's kind of a red flag, because a lot of times the healthcare provider thinks that their methadone dose or their buprenorphine is somehow magically going to control their pain, and it doesn't. And they also should not attempt to increase their methadone or buprenorphine for the purposes of pain control. It just doesn't work well. So if you're looking at and you're trying to figure out what's the safe care plan of care here, if she's not getting adequate pain control, she's at risk for relapse. So it's just kind of the whole context. Even if you're not responsible for managing the pain, if you see it's not being managed correctly, it may impact the things that you are responsible for. Now, maternal discharge planning is important because, again, there's a couple of things. There's the psychiatric problem. That needs to be, if there's a comorbid psychiatric problem, there needs to be a clear follow-up plan. The medication. A lot of times the methadone and buprenorphine had to be increased. So now it's going to have to be decreased. Sometimes that needs to happen before they even leave the hospital, at least a little bit. And then there needs to be quick access to a knowledgeable pediatrician and very short turnaround follow-up with the treatment program. Usually my patients that weren't incarcerated, if they gave birth, we would have them, whoever was bringing them home from the hospital would drive by the clinic, and depending on how they were feeling, I would sometimes go out to the car and just see how they're doing and see, if they wanted to come down on their dose and how much we should come down, and figure that out and get that started for them and make sure that, they appear to be coping okay. So that should happen quickly with the treatment provider. Now, contraception is the other thing. It's a standard recommendation in prenatal care that long-acting reversible contraceptives should be planned for postpartum. And I mean immediately postpartum, like before they leave the hospital. And this is recommendations for this long-acting reversible contraceptive for women of reproductive age is just general, because we have more unintended pregnancies than we should. And so women who don't want to become pregnant because they have substance use disorder or while they're in treatment or they want to space their pregnancies, they just need very ready access to the contraception. And it appears that they're not actually getting it. So this is a recommendation for all women of reproductive age and all postpartum women. And so here we have a vulnerable population who's at risk of having substance-exposed infants, and they should be offered what's called LARC, long-acting reversible contraceptives. But even when they express an interest in it prenatally, one study, this is the only study that's looked at this, indicates that they're on treatment, they express an interest in it prenatally, and they're still not getting it before they leave the hospital. And that's what is the recommendation for anybody, whether you have substance use disorder or not, is that you get your contraceptive before you leave the hospital. So that's an area where, you can consider that a part of the plan of safe care is, for her to be able to function as a parent, she needs to be able to space her pregnancies appropriately. So just remember to look at that and think about what it means for how well cared for the patient is. And then this is just one of the other fact sheets, just to remind me to remind you that you have access to these things. Now, I think we might have, I see a little question-y type thing coming up. I'm not sure if it's for me or if it's for, okay. You know what? So someone has posted a question, and I'm sorry for derailing us, but about reducing the dose postpartum and breastfeeding. This actually, I'm going to take this question now. I think we might talk about this a little bit more. But so here's the question. It says postpartum, the mother reduces her dose amount of methadone. Does it continue to be safe for the mother to breastfeed as she reduces her dose? That's a good question. And yes, going down on her, actually, so little of the methadone gets into the breast milk that it's safe for the mother to continue breastfeeding as she reduces it. It's also safe if she needs to go up a little bit, because it's like 1/100th of a percent of her dose that gets into the breast milk, and then most of it gets metabolized by the baby's liver once they swallow the breast milk. So dose adjustments if for up or down for methadone in a breastfeeding mother, that you don't have to do anything different with regard to her breastfeeding. We want to do as little as possible to deter the mom or dissuade her from persisting in her breastfeeding. So thank you for that question. So let's see, where am I on this slide? Now, the thing that you'll see sometimes is mom looking very tired and sleepy, oftentimes, sitting on the couch with the baby breastfeeding. And this I would tend to see more in the mom where either at the hospital they didn't take my suggestion that they bring the dose down by, 10% or 5%, or I reduced it a little bit when I saw the mom postpartum, and then maybe I should have reduced it more aggressively. So you don't want to overreact to a mom who's tired, but you do not want mom dropping the baby or falling asleep and smothering the baby because her dose is too high. She's going to be tired, and then the physiology is just changing so dramatically that it's really important. It's less problematic with buprenorphine, but it's still important to think, okay, what you need a checkbox that says, what are we doing with this new mom's medication dose? Now, let's see this. Still want me to do something different? There we go. It does need to be individualized. I mean, with methadone and with buprenorphine, a lot of times we say 10% is a good first reduction, but it's not something that's been really deeply studied. So it's really something to kind of negotiate with the patient based on her experience at different doses and different points in time. Again, follow up as early as possible. Now, what I think is of more concern is a mom who might be using alcohol or sedating medications, especially benzodiazepines, because those really knock you out, and it creates a situation where the baby could be smothered accidentally. So since you can't control, nobody can really 100% control that somebody's not going to get alcohol or benzodiazepine, I think it's just really, really important to teach appropriate, breastfeeding, and for that baby to have its own little bed. Some families prefer to have a family bed, but if you're struggling with substance use or you take sedating medications because they're prescribed to you, good breastfeeding technique, and baby has its own bed. And then naloxone is kind of standard recommendation for anybody with opioid use disorder, even if they're in treatment, and that's no different for pregnant women or parenting women. Now, the other thing that comes up a lot is, okay, I've given birth, or my patient or my client is given birth, and now it's time to come off of that medication. And this is really kind of the worst time to come off the medication. If you've had children, who wants to be an opioid with newborn, even mild opioid withdrawal. So unless it's a safety concern, discontinuing pharmacotherapy should wait until breastfeeding is concluded, and preferably until he is sleeping through the night. Now, if there's something up where mom relapses and she's just unstable, well, then, you're going to have to convert to formula feeding, because once you start introducing random substances into the mother's bloodstream, you can't keep breastfeeding that baby. But so the thing is, keep them in treatment, keep them stable, and don't give in to the various pressures to discontinue pharmacotherapy. And these tends to be family and friends. Why do you still need that? It's the kind of pressures that a lot of people who are like, you've been in treatment for a year now. Why do you still need that medication? It costs a lot. The insurance isn't covered anymore because you're not pregnant. Sometimes criminal justice will be pressuring them to get out of treatment. Sometimes their housing, if it's recovery supported housing, they're going to be like, okay, you're not pregnant anymore. You don't need this medicine. Some people will want to get off medication partly because they want to, this is how addiction affects your brain, is that you think you can go ahead and use a little bit. I can use a little bit once in a while now. I'm okay. I'm going to get off this medication so I can do that. And, that's the recipe for disaster. So avoiding discontinuing the medication in the postpartum period, wait until the baby's sleeping, wait until breastfeeding has naturally concluded. And then when is it time to get off treatment in general? Well, when you have enough recovery capital built up, you've got safe, stable housing, social environment, some meaningful activity, engagement, purpose in life. All of the things that make recovery possible for somebody who's not parenting has to still be there for the person who is parenting and trying to decide whether it's appropriate to come off of their medication part of their treatment. So, safety plan. It's not that you want to predict failure for people, but discontinuing pharmacotherapy, unless you've been in treatment a really long time, like maybe 5 years, you have a fairly high chance of relapsing. And it's not the end of the world, but you don't want to not plan for it, because it does jeopardize you and your family quite a bit if you relapse. So the best thing is to have a plan so that you just get right on it. You call in the Marines and it stops there instead of you spinning out into being out of control again. So the decision to discontinue pharmacotherapy should be based on overall recovery stability, and it's something that should be done with your treatment provider. It generally should be done gradually. It should never be done punitively. I think I have talked about, I'm just going to skim this over. We've covered everything on here. Just mention again that if people who are experiencing cravings or withdrawal symptoms may need to have a change or an adjustment in medication. We're talking more generally now, not just in the context of pregnancy and parenting. So here's the key messages. Let's see. Did I cover all these? Identify pregnant women with opioid use disorder as early as possible to get them appropriate care. I think we covered that. Universal screening, validated tools. I think we covered all of this. Behavioral health disorders, comorbid behavioral health disorders. If I could add another bullet, I would be, look at what's happening in your rural counties if you're responsible for a certain geography. And relapse is not a failure. It's part of the disease. Now, Diane, I think this is where we talked about having a 5-minute break. So if you want to, I don't know if I'm supposed to hand it back to you.
Thanks, Melinda. I'll take it over from here. And everyone, we're going to take a 5-minute break. So we'll return at 3:14 or something around there, about 3:14. And we'll see you back in 5 minutes. Thank you. Hello, everyone. Welcome back to today's webinar. Melinda, if you're ready, I'll turn the presentation back over to you.
Okay, thank you. Hope everybody got up and stretched and got something to drink. The remainder of the content moves sort of faster, so fasten your seatbelt. So pharmacologic options for pregnant women with opioid use disorder are methadone and buprenorphine. Naltrexone, the injection Withdrawal, hasn't been studied in pregnancy. There have been some cases of women who got pregnant while they were taking it, but it hasn't been used to deliberately treat pregnant women yet. The other thing that you'll see is that the combination buprenorphine and naloxone, which is often called Suboxone, it's not studied for use in pregnancy, but it's gotten to where now if a woman is already on it, the provider is not switching them over to buprenorphine only anymore. So you may see some women on buprenorphine only and some women on buprenorphine with naloxone. So buprenorphine and methadone are the two approved treatments for opioid use disorder in pregnancy. What does the pharmacotherapy do? A woman who's misusing opioids is going to be having highs and lows followed by withdrawal, and highs and lows and followed by withdrawal, and her stress hormones are going to be going up and down multiple times a day. So the idea is that by stabilizing their withdrawal and their cravings using an opioid medication, you reduce basically this physiologic storm environment that the baby is developing in. It also means that, women who are using drugs by injection stop that risky behavior, and then the baby's less likely to be exposed to infectious agents and other risk behaviors related to drug acquisition are diminished. Now, methadone, I'm not going to give you a full pharmacology discussion here. It's what we call a full mu opioid receptor agonist. And what that means is that it acts like an opioid, it's an agonist, and it's a full agonist, meaning the more you take, the more effects you get. It's like a linear relationship, more drugs, more effects. It has been the gold standard for use in pregnancy since 1970s, so we have 45, 50 years of experience and data. It reduces fluctuation in the maternal serum opioid levels, protecting the fetus from the stress hormones and the repeated withdrawal episodes. Along with comprehensive prenatal care, the use of methadone can make the pregnancy outcome as likely to be that of a non-opioid using woman for this woman in treatment. So without methadone, if she were in active opioid use disorder, she's at risk for intrauterine growth restriction of her baby and preterm delivery and various other complications. But by getting treatment, she's as likely to have a full-term normal growth baby as anybody else. So, and that's just based on the decades of experience with this. Now, what are advantages and disadvantages? The methadone reduces or eliminates, in some cases, cravings for opioids. It prevents withdrawal for at least 24 hours if it's dosed appropriately. It increases physical and emotional health and reduces risk behaviors. And it has higher treatment retention than buprenorphine does. Disadvantages, it can take days to weeks to get on a stable dose. I usually try to do these inductions in the hospital for pregnant women because you could be a little bit more aggressive in that environment, and it didn't take quite as long. Methadone, because it's a full agonist, has a higher risk of overdose compared to buprenorphine. Because the way it's regulated, it requires daily visits, in most cases for at least a while, to opioid treatment programs. The neonatal abstinence syndrome caused by methadone may be longer than that caused by buprenorphine. And actually, this last bullet, it does not have any pharmacologic properties that allow it to block other opioids, but once you're on a stable dose, it's very difficult for any other opioid to have effect. So it's kind of effectively blocks opioids. Now, we've talked a little bit about this, so I'm not going to spend a lot of time on it, but the dose very often will have to go up a little bit in late pregnancy, or it may need to be split in order for withdrawal and cravings to be relieved for the whole 24 hours. And this should always be based on evaluation of the patient. So when you're looking at dose changes and you're thinking, is this person getting good care? Was there a health professional who evaluated the patient before the dose was changed? Now, buprenorphine is also an agonist at the mu opioid receptor, but it is not a full agonist, it is a partial agonist. So there's a point after which taking more does nothing, and that's the ceiling effect. So it's safer because of that, because the more you take isn't going to hurt you, it's not going to help you either, because of its pharmacologic properties. It has quite a few different formulations. There's injectables and implants that are not being used in pregnancy. There's the combination product with naloxone that may or may not be used in pregnancy. So generally, it's safer. Other advantages are that it's lower risk of overdose because it's a partial agonist. It has fewer drug interactions. So if you have a patient who's on seizure medications, antiretrovirals for HIV, this can be a good choice. Can be delivered in an office. It does block other opioids pharmacologically, like it binds the receptor so tightly that other opioids can't bind it, if it's dosed correctly. Now, disadvantages, we don't have 45 years of data. We have 10 or 15. There are clinical withdrawal syndrome symptoms related to it. People, when the drug first came out, thought that maybe it wouldn't have that. And the retention in treatment is a little bit lower. And that may not really have anything to do with the drug. It may have more to do with the way we administer these things. So buprenorphine, naloxone, you may see it used, you may not see it used. It's neither wrong nor right. If you see it being used in pregnancy, it might be interesting to look and see what the justification was. Was she already on it, et cetera? But it's not kind of a sub-issue. So just since the first of the year, I think even this month, a study about late initiation and discontinuation of buprenorphine in pregnancy was released. And these are the things that they found were associated with either starting late, like in the second half of pregnancy, or stopping treatment before you gave birth. Younger age, non-white race, here's our residents of rural counties, fewer outpatient visits to the provider, so maybe less close follow-up, more emergency department and hospitalization type visits, so maybe more sicker or more unstable, and lower daily doses of buprenorphine. Those were all associated with starting late or leaving treatment before you gave birth. So those are very interesting things, very new information to be aware of. Now, similar study, pregnancy, retention and treatment, and this wasn't just limited to buprenorphine. But what they found was the two things that were most strongly associated with not staying in treatment was co-occurring psychiatric illness and prior criminal history or misdemeanor conviction. So it may be that they're sicker or that their life function just got more complicated, and that's what makes it them stay in treatment less. So psychiatric illness, kind of a theme. Now I'm going to mention naltrexone. It is a blocker. It's an antagonist. It's an anti-agonist. So it doesn't act at the receptor. It blocks the receptor. The studies that allowed the drug to be approved did show some reduction in opioid cravings. There's no misuse or diversion potential. There's no expert agreement and there's no studies available on whether or not a woman should be continued on it if she becomes pregnant while she's taking it. Most providers are probably not going to do that unless there's some really extenuating reason. Now, similarly, medically supervised withdrawal is not recommended by the evidence or by expert consensus for pregnant women with opioid use disorder. And that's because of the low rate of completion of the withdrawal and the high rate of relapse if they do complete the withdrawal. So it just basically doesn't work. When you look at a risk-benefit analysis and you take that and you put it next to we have treatments that work or we have a treatment that doesn't really work, you really can't justify doing medically supervised withdrawal for pregnant women. Now, you can't force a pregnant woman to receive medication, so you will see it done from time to time, but it should not be the policy of a treatment program or a provider to say, this is what we do. This is the only treatment we offer. It's just not, the evidence for that being effective or safe is just not there. If it's going to be attempted for whatever reason, a safety concern or an insistent patient or something, it really needs to be case by case. The withdrawal should be conducted in a supervised or controlled setting with a great deal of support. And there needs to be some assessment of benefit to risk, and it's going to be very difficult. I have a hard time coming up with a patient scenario that has benefits that outweigh the risk. So this is just something you should have in your mind when you're looking at how patients are being treated and whether or not they're getting the standard of care. Now, I'm going to mention polysubstance use because the whole idea is that we don't want these babies to have neonatal abstinence syndrome. Well, the medication for opioid use disorder only treats the opioid use disorder. Polysubstance use is very common, and all of these other substances are likely to produce harm to the pregnancy, low birth weight, for example, premature birth, and increase the likelihood of neonatal abstinence syndrome. So you have to be kind of realistic, and you may need to reassure the mother that she's done everything possible because neonatal abstinence is still going to happen. Now, the other piece is, just like diabetes, we give you your medication, but we also expect you to change your diet and get more exercise and deal with stress differently and so on and so forth. Same thing for opioid use disorder. You get your medication, but it is not going to change how you think, how you feel, how you cope. That's something that you have to work on. And usually that's the expectation of behavioral therapy. Now, we don't have, evidence that says you need this much behavioral therapy or you need this type of behavioral therapy. It's very difficult to study behavioral therapy and document a benefit. But we just know that there's a limit to what medication can do. So there should be behavioral therapy. But unfortunately, there's not a rule I can give you that says they need this many times a week for it to work. We just don't know that. Now, I told you this part was going to go faster. So we're already through this section, and the key messages are taken as prescribed. Both methadone and buprenorphine are safe and effective treatment options during pregnancy. The benefits of pharmacotherapy for opioid use disorder during pregnancy outweigh the risks of untreated opioid use disorder. Medically supervised withdrawal is not recommended for pregnant women with opioid use disorder because they don't complete it and they're very likely to relapse. Increased dosing or split dosing may be required in the latter part of pregnancy. And don't forget that the dose may need to come down even in the hospital after she gives birth a little bit. Now, this won't go quite as fast, but it's still going to go pretty fast, is we're going to talk about neonatal abstinence syndrome. What do we really mean about when we use that term, and what can we do to minimize it? What can we do to manage it? Now, this is a good little fact sheet to use. You can give this to family members to help support them with accurate information, as in addition to the moms. Now, neonatal abstinence syndrome is an expected and treatable drug withdrawal syndrome. Please do me a favor, and if you hear anybody say addicted babies, please correct them. Babies can't have addiction because addiction is a behavioral disorder. They are dependent. So they're experiencing physiologic withdrawal syndrome. It's not addiction. So predictable, should be planned for. Now, terminology. Neonatal abstinence syndrome is actually kind of a garbage can term. It basically means any physiologic response to the absence of a substance that was consistently present during pregnancy. So, like we've talked about, the tobacco, prescription medications, some antidepressants cause a withdrawal syndrome, obviously illicit substances. Now, during research, when we're able to like really define and try to quantify what's going on in an infant, we'll try to use the term neonatal opioid withdrawal syndrome when we know that what we're looking at is the result of opioid withdrawal. So that's kind of a subset of neonatal abstinence syndrome. Now, in reality, clinically, we use the term neonatal abstinence syndrome because we realize that we're looking at something much messier than a single withdrawal phenomenon. To give you an idea, 50 to 80% of opioid-exposed infants will develop neonatal abstinence syndrome. Only about half of the ones that develop it will require medication. And as we get better at introducing the non-pharmacologic interventions for neonatal abstinence syndrome, it may even be less. So these are the symptoms. If you look on the left, you have neurologic symptoms. These are the ones that are really troubling to see. The myoclonic jerks, newborn infants are kind of twitchy, and this is just really exaggerated version of that. The irregular sleep in this neurologic column is probably the most problematic. Sneezing and yawning are signs of opioid withdrawal that you're not likely to see with, say, nicotine withdrawal. Everybody thinks a sneezing baby is cute, but it's actually a symptom of withdrawal. On the right-hand side, autonomic is really also a kind of neurologic phenomenon, but what you see here starts to cause problems because low-grade fever, fast breathing, we start to worry, could the baby be having withdrawal and maybe be sick with something else? So we end up doing tests on the baby, and it's then you introduce new risks. Now, the column in the middle, gastrointestinal symptoms, these are the ones that are actually the biggest threat to the baby's development and well-being. They suck excessively, but not very effectively, so they don't feed well. They vomit and they have diarrhea, loose stools, way more than even the loose stools babies have. And they will not gain weight or grow well if you don't address this. So that's where medication comes in. Basically, all of this can be managed with swaddling, skin-to-skin contact, breastfeeding, a low-stimulation environment, all that kind of stuff. It's when the baby's not feeding well or not staying hydrated because they're losing fluids through vomit and diarrhea, that's when you need to start potentially treating their neonatal abstinence syndrome with medication. So it's difficult to predict who's going to get it. We know there are genetic factors, gender factors. Premature babies tend to have less neonatal abstinence syndrome, probably because their neurologic systems aren't as well developed. You may hear a myth that, so I'm going to say the opposite of it. Neonatal abstinence syndrome attributed to pharmacotherapy with methadone or buprenorphine is not worse than neonatal abstinence attributed to untreated heroin use. It's different, and it may be longer because the drugs are long-acting, but it's not worse or harder to manage. Now, this is also a study that just came out since the first of the year that was looking at county-level factors that were associated with higher rates of neonatal abstinence syndrome. So they looked at populations, babies with neonatal abstinence syndrome born in this county, this county, this county, that county. And the counties with the higher rates of neonatal abstinence syndrome consistently had higher long-term unemployment, higher mental health clinician shortage, so fewer or no mental health clinicians, and were remote rural counties. So, you know, if you're professionally involved in dealing with the infants, these are your counties, you know, where more outreach needs to be for moms and, you know, where more services need to be for the babies. So that's just sort of hot off the presses. Now, you see this information in the paper now and on the news because people have gotten a hold of this, that it's very costly. And this little picture that goes with it is you see a baby in the NICU, in the neonatal intensive care unit. And that's the worst place in the world to put a baby with neonatal abstinence syndrome. That is not a low stimulation environment. That does not look dark or quiet to me. So part of where the cost is driven is the fact that we don't, let's just stay on this picture for a minute, is it many of us reflexively out of an abundance of concern do exactly the wrong thing for the baby, which is take it away from mom and put it in a brightly lit, noisy place where it's not swaddled. So there's been a study, I think it comes up on a slide or two, but I'll mention it now, that they did at Yale that showed that they reduced the length of stay and the use of the neonatal intensive care unit by half when they consistently implemented this rooming in with the mom, skin-to-skin contact, breastfeeding support, and the low stimulation environment with swaddling. So we really need to make sure that our babies are getting the maximum non-pharmacologic interventions before we just put them on medication and throw them in the NICU. It doesn't turn out to be the best thing for them. So standardized protocols that screen for, assess, and treat, including non-pharmacologically, infants for neonatal abstinence syndrome. Protocol-driven has been shown to be consistently better for the infants. Nurses and moms and their families, if need be, need to be trained to do the scoring assessment for neonatal abstinence syndrome for the infants. Moms need to understand and be a part of what's going on. The screening tool that's most often used is the Finnegan scale or modified Finnegan scale. The mother's NAS scale, which is the modified Finnegan, is easier to do. It's shorter and it has better inter-rater reliability than the original Finnegan did. The original Finnegan scale, the biggest problem was that it was long to do and the inter-rater reliability was not very good. So bottom line is there should be an assessment tool that's being used to screen and monitor neonatal abstinence syndrome. Now, toxicology testing. Remember, the mom has to give consent for her own toxicology screening. You don't need that for the infant because the infant doesn't have addiction. So you can screen a sample of whatever kind, urine or blood or whatever type of specimen your hospital would use for illegal substances in the infant. Again, if you're using a screening test, it needs to be confirmed positive because the consequences are huge. So mom or baby, screening positive needs a confirmatory test. So again, the breastfeeding is very beneficial to any mother-infant dyad, especially beneficial for the substance-exposed infant because it may reduce neonatal abstinence syndrome. It's safe in the context of opioid use disorder if the mom is abstinent and basically stable. women with, let me see if it's in here. No. Women who have illicit drug use, and I would say, including in this, marijuana use, should not breastfeed. We don't know what that marijuana is doing to the baby's brain development. So, but the prescribed pharmacotherapy and exposure through breast milk is tiny, as I already mentioned. Now, rooming in is a fantastic thing. In most hospitals, it's standard practice. We tend to disrupt it. We've gotten in the habit of disrupting it when we think the baby might have neonatal abstinence syndrome because we want to watch that kid. And some of us are afraid that the mother is some kind of a threat. But they need to be in there with their mom. It does produce a shorter hospital stay and reduces the need for medication. Monitoring for neonatal abstinence syndrome needs to be 5 to 7 days. It doesn't necessarily have to be in the hospital, although most people prefer to do it in the hospital just for safety's sake and abundance of caution. Standardized treatment protocol, screening, and monitoring instrument. Short-acting opioids that are the kind that tend to be abused, whether heroin or something else, typically will present relatively soon, 2 to 3 days after delivery. Methadone and buprenorphine are both intrinsically long-acting, so they're the ones that may not show up until about 4 days, which is why they recommend a bare minimum of 4 days observation in the hospital. As I mentioned, some facilities will want to keep the baby a little longer than that, depending maybe on how far away mom lives and things like that. So managing the mild withdrawal, I've kind of been discussing this all along. All of these non-pharmacologic interventions are absolutely critical. We tend to get real hung up on, using medicine for things. That's part of our culture, but that's kind of not that helpful here. Let's see. I don't know how important it is to individuals in this particular audience to know how to score things. I'll refer you back to the clinical guidance for pregnant and parenting women and their infants to learn more about that. But non-pharmacologic methods. Now, what medication should the baby be given if the baby needs a medication? Morphine or methadone? Those are the two that are recommended. There's a good old-fashioned tincture of opium that is out there, and I think somebody's even doing a study on it, but it's not recommended for use, partly because it's compounded with alcohol. So why? Why would you use it? And there are some studies going on for the use of buprenorphine to medicate the neonatal abstinence syndrome in the infant. But in some places are maybe using that, but it's not to the point where we have evidence to say, yes, go ahead and do it. So evidence is accumulating. You may see an infant treated with phenobarbital or clonidine. You really only see these drugs used in an infant that's known to be withdrawing from multiple substances, or an infant that was on maximum morphine or methadone and was still not feeding and gaining weight properly. So that would be the only time you'd want to see those. The NICU should only be reserved for those infants who can't maintain hydration and aren't gaining weight despite maximum therapy. The NICU is not a fun place for anybody. Treatment plans, the goals are self-regulation of the infant. They need to be able to kind of rein in the jerking, and they need to be able to suck effectively. That's their job, and it's our job to help them do that job. And it's not that we don't want them to cry. It's not that, they have to be completely quiet. It's just that they have to be able to rein in the neurologic responses and feed. Obviously, treatment plan has to be responsive to the individual strengths and challenges and the resources available to the mom. Now, infant discharge planning, obviously, it needs to be very tightly coordinated with mom. Mom may get discharged from the hospital sooner, more and more hospitals are setting it up so that there's a room where mom can stay and continue to room in with the infant. 80% of infants who require medication or are treated with methadone can actually be weaned within 5 to 7 days. That doesn't mean that they're not twitchy at all when they're done. It means that they can eat and sleep and they're gaining weight. They still need to be swaddled and they still need skin-to-skin contact. That's why, you know, the goal of what your treatment goal is not no high-pitched cry, no twitching. Your treatment goal is feeding, hydrated, gaining weight. Home visits, I love visiting nurses. Home visits, early intervention services, social work consults. I'm a big fan of all of those, and they have demonstrated benefit for families of a substance-exposed infant and an infant. So make maximum use of the visiting nurses in your community and the social work and the early intervention development services. A lot of moms will be very worried that, you know, maybe one of their parents had substance use disorder and is their baby going to have it? And the best advice you can give is to tell them that a stable home environment is the best protection you can give, and not returning to substance use yourself. Those are two things that you have some degree of control over that you can do to help improve your baby's future. The other things are just the standard, and especially if they're being prescribed a medication for their substance use disorder, that stuff needs to be out of reach, preferably behind a lock of some kind, and definitely not visible to anybody who might come in the house. It needs to be very clear, what are the things that the infant should need to come back for? Well, if they're not feeding or gaining weight, that they need probably to come back to the hospital at that point. But you need a good pediatrician or a good visiting nurse who can assess those types of things. For when does the baby need to be seen or potentially go back? And then the mom's treatment plan is going to be very important to the infant's safety. Now, there's a lot of discussion now about these NAS children, and there's no evidence that there are neurodevelopmental problems associated with opioid exposure or the experience of neonatal abstinence syndrome. Nevertheless, if a mom has a concern, it's better to have the child formally screened. We know that the children in socially disadvantaged or economically disadvantaged homes may be at higher risk for developmental problems. This is why we want early intervention services, why we want maximum support for mom and baby. I really object to the whole idea that there are these NAS children or these NAS babies as they grow up that have problems, because there's nothing that really predicts that such a thing exists. So nevertheless, a concerned parent, that baby needs a developmental assessment. This just basically says with a lot of words what I just said. Maternal psychological distress, instability in the home environment are more likely to be causes of developmental problems or behavioral problems in social environments or educational environments as the child grows. So, wow, that was fast. Key messages. Infant discharge planning should begin before birth with discussions on ways to reduce neonatal abstinence syndrome expression and severity and promote healthy attachment. Return to substance use is common and should not be reviewed as a failure. You should have a plan in place to address it. Discontinuation of pharmacotherapy for opioid use disorder should be avoided in the immediate postpartum period. You should wait until breastfeeding is completed and there's adequate recovery capital built up. And a woman with opioid use disorder should be counseled regarding contraception and have access to long-acting reversible contraception before she leaves the hospital. So I believe that's I have 2 slides of key messages. Let's just see here. Infants exposed to opioid agonists and partial agonists in utero are prone to display withdrawal symptoms. Okay, yes, they may have withdrawal. Exactly. They're the risk population. as is expected and treatable, pharmacologic interventions or non-pharmacologic interventions should be started first. Encourage them to breastfeed, and there's really no evidence that pharmacotherapy is impacting long-term development of these substance-exposed children. So one last pitch for our set of fact sheets over at Dear Old SAMHSA. And finally, worth the questions. And thank heavens I've left you a couple of minutes. So Diane, do you want to moderate questions? I don't know if people need any explanation about how to submit them.
So, thank you, Melinda. Does anyone have questions for Melinda today? Please post in the chat or Q&A section.
While we're waiting, I can just say I see somebody earlier on made a comment about medical education, and I think, improving medical education about how these issues are treated with regard to substance use disorder and substance use in pregnancy and its treatment. There's vast room for improvement there. There's no single solution for that because there are so many medical schools. Looking to see if there's anything else I can respond to. So Diane, I don't see anything else coming in. I'm happy to wait for a minute in case people are having technical difficulties. Okay, I see a question here. Some hospital nurses are pouring out breast milk from moms who are in residential programs, coming over to nurse, or not working with these women to accommodate their visits. Can you discuss? Well, the first thing I would discuss is that's just abominable. That's very unprofessional. And it's against what not only the evidence, but the expert recommendations. It's in the baby's best interest, regardless of what, an individual human being thinks of another individual human being. It is in the baby's best interest to receive breast milk. The evidence for the benefits of breastfeeding is huge. And it's just, why would you interfere with best practice? I think if I observed that going on, I would definitely say something about the ethics of that behavior, but also about the harm, the potential harm of that behavior. Babies need breast milk. And it doesn't matter if mom is on medication. They need breast milk. There is, I'll just say there is some confusion, I think, because you hear studies about women who receive opioids for pain. And is there a higher risk of some kind of birth defect or developmental problem? And there's some indication of a possible risk. But when you're talking about addiction, it's not the same because the mom was already using the opioid and she has a serious disease that's not going to go away by itself and is associated with very bad outcomes for herself, her pregnancy, and the developing, infant once it's born. So the risk of opioid exposure in that setting is very different. So if I try to be as generous as possible to these people that you have described as pouring out breast milk, maybe they're misguided by that type of information and not understanding that the risk is different in a mom who is using opioids to start with. So I hope that gives you something to go on. That would be a very stressful situation to find yourself in. There any other? I'm trying to look at the chat box, and I'm just hoping I'm seeing the whole thing. I think I am. So I don't see other questions at this time, Diane.
Okay, thank you, Melinda, and thank you for your time and your expertise today. It was awesome. So thank you so much, and when I'm going to go ahead and take over and conclude this presentation with to share a little bit more about the credits of statement. And so we're going to conclude today's webinar. Your browser will take you to an evaluation on FADA's new website. If you want to receive CE credits or a statement of credit for this event, please complete the evaluation. You will be prompted to register or sign in to complete the evaluation. You can register as a visitor at no cost. For CEs to be reported to CE broker for Florida licensed healthcare practitioners, you must provide an accurate Florida Department of Health license prefix and number the first time you register. After you register or sign in, you will be directed onward to the evaluation. You may consider using the same email address when you register for webinars through our WebEx link and when you set up your profile in FADA's system. This helps connect your attendance and your profile. You will get a second opportunity to complete the evaluation through a follow-up email later today in about 30 minutes. The sender will be messenger@webex. Evaluation will close at midnight on Saturday, March 2nd. We do not email statements of credit. Instead, after we verify attendance and completion of the evaluation, a statement of credit will be generated as a journal entry within your profile. Thank you for participating in today's webinar. We'd also like to recognize and thank especially the Florida Department of Children and Families Office of Substance Abuse and Mental Health and for JBS International for funding today's education. Have a great rest of your day, and please hold for the evaluation.